This week on Diabetes Connections, more and more people with type 1 are using GLP-1 receptor agonists. You know these medications, brand names like Ozempic, Mounjaro, Wegovy, and Zepbound, but none of them are specifically approved to treat type 1. Some of the first studies are underway right now studying the safety and effectiveness of GLP-1s in people with T1D, but that hasn't stopped thousands of using them off-label or to treat obesity with type 1. We're talking to an endocrinologist and a clinical pharmacist about what these drugs do for people with type 1, why they do prescribe them for some of their patients, who they will not write a prescription for, and, I know you're already asking, how they get insurance coverage. This podcast is not intended as medical advice. If you have those kinds of questions, please contact your healthcare provider. Hey, everybody, welcome back to another week of the show. I'm always so glad to have you here. You know, we aim to educate and inspire about diabetes with a focus on people who use insulin. Before we jump in, and I'll keep this quick because I know this is a very high-interest topic you have been telling me for months. You want to hear more about this? I do have to tell you that registration is open for our 2 Moms Night Out events this fall. That is Minneapolis in September, and we are going to Phoenix in October. These events are for moms of kids with diabetes and for women with type 1. You can find out more at diabetes-connections.com. Click on the Events or Moms Night Out tab, and you'll get all of the information, and we will be updating that this month to tell you where we will be going in 2026. I had some travel last month and into this month, so the schedule got a little bit changed. In the news, got moved around a little bit. And I was about to announce we're going to be back to our regular schedule, but I have been summoned for jury duty. So as this episode goes live, I probably will know more whether I will be seated or dismissed, or I've never served on a jury before. So I've never even been called. And so I'm not really sure what's going to happen here. Might be all settled by the time you're listening to this, but I will keep you all posted on social media. I am Diabetes Connections on Facebook. I am Stacey Sims on Instagram and on LinkedIn. And I still have an account on Twitter. I have an account on Threads. I don't have an account on TikTok, but I'm not active right now on most of those accounts. So Facebook, where we also have the Facebook group, and Instagram are the best places to go to keep up on any last minute changes, I'll say, about the show. Okay, so later this month, we will be hearing a lot of news and studies coming out of the annual ADA Scientific Sessions Conference. Last year when I was there, I didn't hear anything specific about GLP-1 medications for people with type 1 until the very last day. But I think it's going to end up being one of the top stories there this year. I'm not going in person. I will be covering it virtually, so definitely stay tuned for a lot more from ADA. There are several studies that we're waiting for about GLP-1 medications and people with type 1 that will be presented at ADA. I don't know if these are conclusions, the end of these studies, enough at least to submit for FDA approval, or if they are ongoing. So we will find that out. But right now, as I said, the medication labels for Ozempic and Mounjaro, which are prescribed to help people with type 2, specifically say they're not intended for use with type 1. And the same medications, semaglutide for Ozempic and tirzepatide for Mounjaro, are also labeled as Wegovy and Zepbound, and then prescribed for people with obesity. And among people with type 1 with obesity, the use of GLP-1 medications spiked 800% from 2008 to 2023. I will link up that study and that story in the show notes for this episode. My guests are Dr. Adam Spitz, an endocrinologist, and Georgina Farrow, a clinical pharmacist. And they both work at Novant Health here in Charlotte, and they work together. I've known Dr. Spitz for years. I think I first interviewed him back when I was a health reporter at WBTV, the CBS affiliate here in town. And that was a long time ago. And a lot has changed. And this feels like it's going to be a sea change for people with all types of diabetes in the years to come. But it's not for everybody. And there's a lot of precautions, as you can imagine. You had a lot of questions about these medications. Thank you so much for sending them all through the Facebook group, Diabetes Connections, the group, and my conversation with Dr. Adam Spitz and Georgina Farrow right after this.
Did you hear the pod drop?
Did you know all the sounds used to make that song come from a site change with the Omnipod 5 automated insulin delivery system? Pretty cool, huh? With Omnipod 5, pump site changes are simple. The pod lasts up to 3 days, 72 hours, and to change it, you just fill up the pod with insulin, place it on your body, tap a few buttons in the Omnipod 5 app, and you're ready to go. There's no tubing to prime like with traditional insulin pumps, and it's virtually pain-free. So you never have to see or handle the insertion needle. Want to try Omnipod 5 for yourself? Request a free Omnipod 5 starter kit today by visiting omnipod.com/diabetesconnections. Terms and conditions apply. Eligibility may vary. Dr. Adam Spitz, Georgina Farrow, welcome to Diabetes Connections. This is a very, very anticipated episode, judging by the conversations in the Facebook group. Thank you for being here. Welcome to both of you.
Thank you.
Thank you for having us.
Dr. Spitz, why don't we just start with a little bit of background if we could? These medications are not as new as they seem, but the demand and the media coverage certainly is. I know we could do a whole hour on this, but briefly take us through your experience maybe with what I'm umbrella terming calling GLP-1 medications, but that's not exactly accurate.
Well, these drugs first came on the market in 2005, and then every few years, something newer, more potent, better would come on the market. And then once we had Ozempic, and these were all for type 2 diabetes, and then once we had Ozempic, it was so much better than everything before it. And because it was weekly, easier to use, fewer side effects. And so once we had that, that's when people started seeing the potential for so many people using this. And then they were the first to come out with a weight loss version, or the second one to come out actually with a weight loss version called Wegovy.
The conversation seems to be getting louder and louder around people with type 1 taking these medications off-label. They're not approved. Studies are beginning. Tell me a little bit about the conversations you have with your patients over the last couple of years.
Well, as far as off-label, these drugs, semaglutide and tirzepatide, are approved as Wegovy and Zepbound, respectively, for obesity. They're just not approved for type 1 diabetes. But if you have a type 1 diabetic whose body mass index is above 30, so they meet the criteria for obesity, they're not contraindicated. They're just not approved for type 1 diabetes per se. They've been studied for that, and actually semaglutide has a study going on now to see if we can specifically improve control. And there was a study on Victoza some years back, and it did show benefit in diabetes control, but not enough for the drug company to apply for the FDA for that. The most important thing to remember, I can't emphasize this enough, is that this is not a substitute for insulin. This is not a treatment for type 1 diabetes. You don't want somebody to use this drug and then stop their insulin. Their insulin requirements will go down, and Georgina can elaborate on that. And she can talk to you about how, as she titrates up the drug, she follows them and then adjusts the insulin. But it's very important that they understand that they still need their insulin to survive. And so that's part of the conversation that I have. I discuss a lot of the side effects, the rationale. I go over with them that this is not a substitute for healthy lifestyle, but if you could lose this much weight with healthy lifestyle, if you add the drug to it, well, it's that much. Likewise, if the drug can give you this much weight loss, if you add healthy lifestyle to it, well, it's that much. So that's part of the conversation.
Georgina, I want to get to that in just one second, but I have to ask, Dr. Spitz, do people think it is a substitute for insulin? I mean, I'm not talking about the general population. Like, do people with type 1, are they, that would really worry me.
They're a little more savvy than that, and I have not yet come across a patient, but I don't want to take that for granted.
Great. Okay. Just making sure, because that would be alarming. Georgina, let's jump over to you. Georgina, tell me a little bit about titrating this, because it's not the kind of thing you want to start just guessing at dosing for people with type 1. I mean, that's a silly thing to say, but how do you talk to patients about this?
Yeah, so usually when we're starting one of these medications, we've all heard there are potential side effects with these medications, mostly gastrointestinal. So kind of taking that into account with sometimes these diabetics have some gastroparesis at baseline. And so we kind of have to figure out what the cause of, if we're going to have these gastrointestinal symptoms, where they're coming from. The biggest thing with when starting a type 1 specifically is, like Dr. Spitz said, they will always be on insulin. GLPs themselves can't physically cause low blood sugars. They're dependent on your glucose levels, whereas insulin, they work dependent. Insulin works independent. I'm getting my words messed up here. So basically that is to say, if you have someone with a blood sugar of 77 and they take insulin, it can drop it down to 57. have someone with 77 blood sugar, they take a GLP, it's not going to cause low. However, in someone that has type 1 diabetes, they're always going to be on insulin. So when you're adding that GLP on, is that causing the low blood sugar, or the fact that it's now lowering the blood sugar and then the insulin's lowering it that much further? So you have to take into account that when you're starting these GLPs, you're always going to have to dose reduce the insulin when you're first starting them. Granted, you do have to take the individual patient into account. If they're coming to you with blood sugars in the 300s, you may not dose reduce because their blood sugars are already so high. But if somebody's coming to you with reasonably well-controlled blood sugars and you're starting a GLP, typically, sometimes we fall around the 20% dose reduction in insulin. We really take it as the individual patient, but you do want to make sure you're not causing them to then have a hypoglycemic episode by adding on the GLP to the insulin medications.
Got it. Maybe I should have started out with this question, but Dr. Spitz, what are these medications doing, especially in people with type 1 diabetes?
Well, in a type 2 diabetic, which is where they were used exclusively for many years before recently, they were basically augmenting a gut hormone. When you eat a meal and your food gets into the small intestine, before it's even absorbed into your bloodstream, the gut releases a hormone, GLP-1. And that hormone tells the cells in the pancreas that make insulin, hey, food's on the way, get ready. So GLP-1 is like the warm-up hormone for the pancreas. And that way, when your blood sugar starts to go up from the meal, bam, pancreas releases a lot of insulin. Now, in a type 1 diabetic, you don't have the beta cells to make insulin, so you're not getting that effect of the drug. So it is got three major effects to think about. One is it crosses the blood-brain barrier and it affects the centers in the hypothalamus on appetite. So that little signal in your head that says, I want to eat, it lessens that signal. It turns off the message. The next thing it does is it slows stomach emptying. That's what creates the nausea, but it also creates a sense of fullness. So you feel full faster because the stomach is not emptying food as quickly. And the third thing that it's doing, and we don't know how much of an effect this is in type 1, is that it's affecting the cells in the pancreas that tell the liver to crank out glucose. And so we don't know. That's an important component in type 2, how it works. I don't know yet whether that's an important aspect in our type 1. So those are the three major mechanisms of action of these drugs.
One thing I've heard that it sounds like maybe mistaken information, or maybe I'm not understanding it correctly. One thing I've heard is that it affects the production of amylin, which is supposed to be the hormone that makes you feel fuller, but you didn't mention that.
That's not something that I've heard of, that it raises amylin. There's actually, amylin is its own separate drug. And
Right.
And in fact, there are now studies, I think Novo has a study ongoing, adding amylin to semaglutide to see if that enhances blood sugar and weight loss. That's not something I've heard of, but
I think that's just a community confusion because, as
okay.
you said, it's really affecting the brain.
Right.
And I think people assumed that it was, I'll look into that, but I think that's like a little misconception that we have.
Well, and I think, amylin is also secreted from the beta cells, right? So in someone that's a type 1, when they don't have functioning beta cells, regardless of if GLPs don't have any effect on the beta cells directly. So it doesn't seem directly that it would impact the amylin levels.
Yeah. But I did see that study. So I think we're all on the same page here.
Yeah.
It's just interesting. You started talking about how, this is not an off-label use when you're prescribing it for obesity. And there is also a lot of chatter about insulin causing weight gain. Can you take a second and just talk to us about that thought and obesity in people with type 1?
Sure. Well, first of all, type 1 patients have as much, if not more, obesity than the general population. It's a huge issue for type 1s. And part of the problem that's contributing to this is that when someone who doesn't have diabetes, when their pancreas makes insulin, all that insulin first goes to the liver. The liver is a very important source of glucose. That's why you don't die in your sleep of low glucose when you're not eating. The liver is cranking out glucose. In a type 1 diabetic, the liver's cranking out a lot of glucose. And the problem is, the pancreas is not making insulin. So a non-diabetic, the liver is extracting a lot of that insulin straight from the pancreas. It's a very high concentration of insulin, and that controls the liver's production of glucose. In a diabetic who's injecting insulin under the skin, that insulin has to diffuse all over the body. So you don't have that really big, ginormous concentration trait at the liver. So in order to get that high liver concentration to control the liver's production of glucose, you need about twice as much insulin in the body as a non-diabetic would have. And all that insulin is stimulating appetite, it's stimulating body fat deposition, and it just makes it harder. One of the discussions I have with my patients is that I want them to understand, hey, this is not your fault. However, the second part of that phrase is, you're the only one that can change it. And the way to do that, in addition to the medication, is to lessen the insulin requirement by cutting back on the carbs, not doing keto, but cutting back the carbs, and disposing of the glucose by non-insulin means. Working muscle at low to medium intensity, so like walking or an easy jog, can take up glucose without insulin. So all of that is going to lower the insulin requirement and lessen the body fat problem. So if you add that to the drug, you do that. That's where the lifestyle component comes into the drug. If you do those two things together, you'll get much more success.
Georgina, it looked like you wanted to say something about this too.
I was just going to say, I wanted to reinforce what Dr. Spitz said in the beginning, because I think there's a common misconception that obesity is more so just in the type 2 diabetes scenario, but we are seeing many, many patients in the type 1 diabetes situation where there is obesity. And I think, as we'll probably continue to talk, that's also where these GLP medications play a huge impact, is the reduction of obesity.
Yeah, I mean, and then let's start talking about that, Dr. Spitz. I assume you have some success stories. I don't want to overblow this, but let's talk about when it works.
Sure. I have one, and then I'm going to turn it over to Georgina. Georgina I am working closely with my patients. I have a huge commitment. I've got a very large type 1 diabetes population that I've accumulated over 30 years. However, Georgina is sort of my boots on the ground in the trenches there, working closely with the patients between their visits with me. And so I saw a patient yesterday, and she's type 1 for many years. She had obesity, and she had a gastric sleeve, and she lost a lot of weight, but as many do, she regained it. She has the extra additional difficulties that we described earlier. So I sent her to Georgina. She started semaglutide, saw her yesterday, and she's down from 256 down to 206.
Wow.
And her hemoglobin A1C, which was running about 8 or 8 and change, is now 6.5. And she started crying. She's like, I haven't seen a 6.5 and I can't remember, she said. Because, it's not just about the numbers and the scale, the quality of life. And don't forget that our type 1 patients, that diabetes, it's like an anvil sitting on top of them. It is really rough. And anything that we can do to improve the quality of life, not just the numbers, is a win in my book. So I'll turn it over to Georgina, because she many great and also difficulty experiences.
Yeah, so let's talk about that.
I have a few patients here. I could just kind of, obviously I won't say their names or anything, but kind of describe the situation. Very similar to what Dr. Spitz was just laying out. But let's talk about this patient specifically. Has been a type 1 diabetic with obesity. BMI was between 30 and 39. Each time we talked to him was a little bit different, but since 1992, has been on insulin since then, was not able to control his A1C very well, was started on Ozempic, was on it for 4 years. In that time, he was able to lower his daily insulin requirements by 55 units per day. His weight had gone down. I don't know if I have the original one here. He had been down 50 pounds. This story more so was about when he lost coverage, which is what we're going to talk about today more. Since being off of the medication, he's already gained back 15 pounds in a month, and his insulin requirements have gone back to where they were in the beginning. So that's kind of, I guess, the opposite of a success story. It was a success story at first, but it could be a success story if we figure out a way to get him back on this medication. Another patient that we had here, her A1C dropped from 8.6% to 6.4% after being on Zepbound for 1 year. Her weight started at 230 pounds, went down to 173 pounds in this time period. And her insulin to carb ratio went from 1.8 to 1.2, or 1 to 8 to 1 to 12. So all that to show it's, not only lowering A1C, it's lowering weight, and it's, like Dr. Spitz mentioned, improving their quality of life. The amount of times I've spoken with a patient where they've either been in tears or they've just said, I haven't felt like this in 20, 30 years. And sometimes it's just kind of, I describe it as, lighting a little fire under the butt, because, you kind of get in this situation where no matter what you do, You're trying to dose your insulin right. You're trying to follow everything that your provider is telling you to do, but you just can't get really good control of your blood sugars. And they're doing the exercise, they're doing the diet. And so they just kind of get into the situation where they're like, why do I have to keep trying when I'm trying so hard and I'm not seeing these results? And you get them started on one of these medications and they have, a 10-pound weight loss over a couple months, and it gives them more energy. It gets them more excited to take this more seriously again. And it kind of gets them, I describe it as this positive reinforcement. Like, they start to see these results. They start to do better with their insulin management. And then they have a little bit more weight loss and a little bit better with their insulin management. And next thing you know, they're back where they were when they were first diagnosed and doing really, really well. And it just, the happiness that I see in their eyes and how proud they are of themselves, it's unbeatable. And it's like the fact that one medication can do this for somebody in addition to insulin. And then there's these barriers that we have to getting these medications. It's just really frustrating in our roles.
All right, let's talk about it. The number one question that came up in the group, most people said, look, I know this is great. How do I get it covered? Dr. Spitz, go for it. Right back to our conversation. But first, Diabetes Connections is brought to you by Dexcom. When I think about our family's use of CGM and Dexcom, it's hard to remember how we did things before. Truly, how did we manage when Benny needed something like 10 finger sticks a day when he was a toddler? We thought it was amazing to switch to Dexcom when it needed to be calibrated 2 times a day. Now, Dexcom G6 eliminates finger sticks for calibration and diabetes treatment decisions. Benny's fingertips looked just awful when he was in elementary school. When they got wet, you could really see how pitted and scarred up they were from all those finger sticks. Now they're healthy and smooth, which I never thought would happen back then. He doesn't even remember. But to me, it's everything. Learn more. Go to diabetes-connections.com and click on the Dexcom logo.
You know what? I'm going to give that one to Georgina because it's very, very, it's tough.
Yeah.
It was a lot easier about a year or two ago. And now that everybody wants this medication, it's gotten a lot tougher. And
Georgina.
I'll give a little bit of a background. Just like Dr. Spitz said, about 2-3 years ago, to get these medications approved, we were typically mostly seeing this in endocrinology space. And if Dr. Spitz put in a prescription for it, let's say the prior authorization was denied, if he didn't appeal, most of the time it would get approved because they were putting this decision in the hands of the prescriber, the clinical decision-making of the prescriber. Over those past 2-3 years, again, the amount of times this medication has been prescribed, we see it all over social media. The insurance has now, these companies have started putting limitations on when they will cover these medications.
Right.
Do I agree with all the limitations? Absolutely not. I think there is a spot there where, they are obviously trying to save money, but we also need to take into account the clinical benefits. So they are basing it just on FDA approvals. We know that GLPs do not have FDA approval in the type 1 setting. So the process now, when I first get a patient that comes to me in this, exact situation, is I will first look to see, okay, can we get this approved for obesity alone? Just take the type 1 out of the equation. That's going to be your best bet. If their insurance covers obesity medications, we'll be able to mostly figure it out as long as their BMI is either over 30 or over 27 with a comorbid condition, which most people with type 1 diabetes have hyperlipidemia, hypertension, something else going on. If we can do that, that's great. The problem is a lot of insurances now, they either cover weight loss medications or they don't. So if they cover weight loss medications, they still require prior authorization, but you can get them approved as long as you have the correct information in your documentation, which sounds maybe like what you've been talking about before with the thing that they filled out and kind of put in their documentation to get the appeal approved. So there is very specific wording that you have to get that approved. You miss one word and they will not approve it. Wow. So that's one step. The next step is if their insurance does not cover obesity medications at all, then that's when it gets very difficult because then you do have to try to get it approved for type 1 diabetes off label to help with insulin resistance, stability of A1C, that kind of thing. And that's where it has to go to either the appeal level or the peer-to-peer level. And I will say, I have submitted some amazing appeals and I spent hours and hours on them, perfecting them, and they still were denied. So that's where it gets really, really difficult. And you also have to keep in mind, because some people will ask, well, Zepbound was approved for those with sleep apnea. It was approved for those with obesity with sleep apnea. So you can't just get Zepbound approved for somebody because they have sleep apnea. They have to have the obesity diagnosis first. And then another level of difficulty after that is, okay, so I had a patient where he had sleep apnea, he was obese, and I tried to get Zepbound approved for him. They actually denied it, saying that in the SURMOUNT OSA trial, which is the trial that got Zepbound approved for sleep apnea, they excluded patients with type 1 diabetes. So they denied it because those patients didn't have type 1 diabetes, even though he was obese with sleep apnea. That adds a whole nother level of complexity. I am hopeful that as we continue to see all these other indications, improving kidney function, helping with the heart function, now MASH, sorry. Massel D.
Fatty liver.
Massel D. Oh, yeah, sorry, we're talking. Yeah, fatty liver.
Lay people.
Yeah, sorry.
That's fine.
So we're seeing all these other indications. So my hope is hopefully we're at the peak of insurances denying. I hope we're coming back down the other side now where they are going to start taking into account all these other benefits of the medication, because I really do think it's a disservice to our patients that could benefit from all these other indications, which to me, I think that most of these benefits are probably coming from the weight loss, the anti-inflammatory effects. So we're in a difficult time right now. We definitely are. This has led us to use, during the time of the shortages, to use some FDA-approved compounding pharmacies, which that's become now more difficult. But
yeah, well, let me just jump in and ask about that, because that was my next question for you is, what about compounding pharmacies? Because you hear some good and some really not good about fake stuff and about dangerous stuff, but then you see these big companies with big commercials about it.
The way the law is written, if the drug is on the FDA shortage list, then a licensed compounding pharmacy, licensed by either the state or the feds, can use the FDA-approved raw ingredient, meaning they can get the raw ingredient from the same place that the drug companies get it, and then compound the medication. So we were actually doing that with some of our patients, and it was working out quite well. And it was not cheap. It was a couple of $100, but better than $1,000 per month. Now, since both drugs, tirzepatide and semaglutide, are off the shortage list, you can't do that. So there's little workarounds. Some compounding pharmacies are saying, well, this patient also needs vitamin B6 with it. So they're trying to do it that way. That's a very slippery slope, and we don't want to go that route. And then what you're talking about is the copycat drugs. This is where, who knows? I mean, there could be some guy in the mountains in his basement going, now, which stove had the meth and which stove had the semaglutide? I'm getting them mixed up. But that's an exaggeration, but not by much. Right. These copycat drugs, you don't know who's making it or what's in it. And we discourage that. So it is a problem. And Lilly has at least cut the direct-to-consumer price somewhat. You can get the lower doses now of the Zepbound, the lowest 2 doses, for $350 a month. It's not cheap, but it's better than $1,200 a month.
Yeah. One of the questions I got from listeners, and I've heard this from several adults I know with type 1 who've gotten these medications, is, should I just ask my doctor to diagnose me with type 2? Because that's a way that some people have. And if you don't want to answer, I know you both.
I can answer that. I don't think that's a smart idea. Once again, like with saying, oh, this patient needs B6 too, or they need 3.2 milligrams per week of Zepbound, not 2.5 or 5. It's a slippery slope. And whenever I think about a treatment, any intervention in medicine, I've been doing this for years. I think in reverse. I think to myself, okay, things are not always going to go your way. There's always going to be a risk and a side effect. What if this person winds up in the ER with small bowel obstruction or something like that? Can I look back on that and say, this is most unfortunate, but that was still the right decision at the time? Or will I look back on that and say, oh boy, that wasn't the smart thing to do? That's my little yellow light. So that is the reason why I don't go down that route.
I think too, there's different levels of that, right? So if someone comes to you, they have no C-peptides or antibodies, we're completely positive, 100% it's a type 1 setting. That's not a situation where you would do that. Whereas there's someone that's had type 2 for years. They were first diagnosed as that. became more and more and more insulin resistant, kind of went more towards that type 1 scenario, would you leave a diagnosis like, would you say type 2 now treated with insulin, type 2 now treated as type 1? It is very specific. Like when I'm trying to get these medications approved, if I have anything about type 2 in the diagnosis code, I can get it approved. If I don't, if it just says type 1 diabetes, that's when they'll deny it. But I do get some patients from some of my providers where it is like type 2, but now being treated as type 1 or being treated with insulin, like insulin requiring. What are your thoughts on that?
Well, that's much easier. There's this belief that type 2s are just obese insulin resistant. And that's not true. Type 2s have a component of where their beta cells, their insulin producing cells, are not working properly. And there's a variable amount of that component. And there are many type 2s that are practically type 1s. They only make a small amount of insulin. They may even have one of the antibodies positive, but we don't automatically call them type 1. So in a case like that, with obesity, but they don't make much insulin, that's still going to be a type 2. We actually see that in certain populations. We see that in the Asian population. Their type 2s are much more insulin requiring. And literally hot off the presses, I just read this last night, a study from one of the southern states looking at a couple of thousand type 2s showing that African-American persons have a greater incidence of severe insulin deficiency. So they're still type 2. Type 2s are very heterogeneous. So that they require insulin doesn't make them, we don't call them type 1. But if you have someone like Georgina said who's clearly type 1, that's a very slippery slope to say, okay, I'm going to call you type 2 so we can get the medication. That's something that I think that could potentially get you to lose your license or your job.
I'm so glad that you took the question. What a great answer. I mean, I'm glad I asked. Another question I got from listeners was what happens or what would you recommend? And again, I know this, you can't recommend for individual patients, but what about when insurance companies want to switch people from brand name Ozempic to brand name Monjaro or, the weight loss medications? They're not exactly interchangeable. Georgina, what do you tell people?
So this happens a lot. I will say, obviously with the most recent data coming out and just with experience, we are seeing slightly more of the weight loss with the tirzepatide versus the semaglutide. However, that does not negate how well semaglutide helps in these situations as well. So in some of those situations, it's kind of like something is better than nothing, right? If they're going to switch you from one that's working better for you to this other one, it's still going to help with the insulin resistance. It's going to still help with the blood, like maintaining those more stable blood sugars, which is what I see a lot with adding on the GLPs. It really stabilizes the peaks and the valleys. But yeah, I mean, at the end of the day, they're still providing that benefit. Is one tolerated better versus the other? That's very patient dependent. Talking through them with it, like, okay, this is where, I've kind of come up with a dose to dose comparison, like going from one to the other, but people do that differently. I like to be more on the conservative side, especially if their insurance is covering it and it's $0, $5, $10 a month. I'm like, I would rather do this and you not have the side effects and we can kind of get you to that dose eventually versus jumping you up to too high of a dose and then having those side effects right away, because that can scare them away from a medication that could potentially be very beneficial for them down the road. So at the end of the day, I mean, we're talking about the two main ones, right? Wegovy, Zepbound. They're still going to be getting benefit from it, whether one is better than the other. At the end of the day, like I said, I think it's better than not having it on board.
Just before, I just want to make sure while it's a guy thing, it's in my head, I got to spurt it out.
Go for it.
I'll spit it out. Before we forget, there's a couple of like real just pearls. One is not a substitute for insulin. It's not a treatment, a replacement for insulin. But the other is that you have to be on this drug long term. There are success stories of patients coming off the drugs, but that is really the minority. So part of and I think this helps actually in narrowing down the number of people who are prescribed, is good counseling beforehand, because some patients will say, you know what, I'm not sure if I want to make a commitment lifelong to this. Let's wait. Let me think about it. You've got to stay on this to work. Remember I said it turns off a little voice in your head? Well, that voice is still there and it's going to come right back if you stop the drug.
Is there anybody who shouldn't take it? I had a couple of listeners who asked, what about other, not just like comorbidities, but other conditions that maybe you should think twice?
Well, these drugs slow stomach emptying. Now, that said, I do have some patients, and Georgina has some patients with diabetic gastroparesis where they've got nerve damage to the stomach and that slows the stomach emptying. So we've both done this where we're just very careful with the dose and the patients have done fine. But I also have patients with severe gastroparesis who are taking medications for nausea all the time, that's somebody who shouldn't use it. I think probably the more common thing is you need a reliable patient. You need somebody who is doing a good job managing their diabetes as far as not necessarily a great A1C, but someone who's doing a decent, at least a medium good job of self-management, because there are risks. If someone's getting nausea and it's bad, and then they can't eat or drink, I got to know that right away. I need a patient who I can rely on to give me feedback. We've got to get feedback on how their blood sugars are doing. Glucose sensors have made this dramatically easier because we can follow that. Patients, their sensors upload to the web. So let's say Georgina starts the medication. She may decide in 2 weeks she's going to go to the website, the Dexcom website or the Libre website, look at their blood sugars and make sure everything's okay. So these are the kinds of things that we like to do. So if we've got somebody who's doing a finger stick 3 times a week, that's not somebody who I'm going to prescribe this.
And to add on to that too, with the reliable patient is if they are stopped on this medication for whatever reason, insurance stops covering it, they hit a financial burden, can't afford it for a few months, and then they start it back up again. They need to know that they can't be going. If they've titrated up to a 10 milligram dose of Zepbound, they should not be starting that back up again. The timeline that I usually use is about 3 to 4 weeks. But for some people that have said, oh, I've had nausea when I started it, took me a while to get over it. For some of those, I'll even start back over at the beginning. Is it the most ideal situation? No, because it does take 4, 6, 8 weeks for people really to see the full benefits of these medications. But again, coming back to the side effects of it, you could have someone that you went very, very slow, got them up to, 10 milligrams, was doing very, very well. They go off of it for a month or 2 months, start it back up again, and they end up in the hospital with severe nausea, vomiting, diarrhea. I've seen that a handful of times now. And when you talk to the patient, you're like, we talked about this. We said, you weren't going to do that. She was like, oh, well, I was feeling good. So I figured I would be okay. But yeah, the reliability of the patient, there is a lot on the patient. I think with these medications, something we have to be very cautious of is they are causing weight loss. And they are even causing weight loss in the people that are not doing the diet and the exercise, that's where there's that kind of that line where you have to be, as a provider, you have to give that education up front. Like, yes, you are going to see weight loss. You are going to see appetite suppression, but this is a hot topic right now. We need to maintain the muscle mass. So you need to be getting in your protein and taking your exercise. You need to be following these good diets and these good exercise, because then you kind of rope in that psychological aspect of this where people are losing all of this weight and you're not taking into account the downstream effects of it. As if you do stop the medication, what's going to happen? Like Dr. Spitz was saying, that weight can jump back up again if they didn't make any of those dietary or exercise changes in their lifestyle. So there are a lot that go into these medications. They're not, people say they're easy medications to prescribe. They are not at all. There is so much education that needs to go into it. And the amount of patients that I've come across that have either it's been prescribed elsewhere or they didn't get any of this education. And when I tell them, they're like, this is news to me. Why, where is this coming from? And then fortunately, I have the time to kind of sit with them and explain everything that Dr. Spitz was just saying. And they're like, oh, okay, that makes sense why this medication wasn't working as well for me so far. So there's all that to say, there's just a lot that goes into prescribing these medications.
I'm glad you mentioned the stopping and starting. That was going to be a question that I wanted to ask for sure. Listen, we can talk lots and lots more about this, and I'd love to have you back on maybe when this is approved for type 1 to do more tips and tricks. But yeah, fingers crossed. So let me ask you for an opinion, and not necessarily, I'd love you to answer this as a clinician, but I've also, Dr. Spitz, maybe someone who's just worked with people with type 1 for, like you said, 30 years. How significant do you think this is going to be if and when approved for type 1 or even just more general use for people with type 1?
I think it's going to be, in the history of advances, it's going to be a game changer. It's already been a game changer for our patients who can get it. When I was in my training, we just didn't really think about obesity in type 1. And now we see it's a huge problem. Any type 1 who's got poor control, when they get the control down, even if they're doing a great job with lifestyle, body weight goes up because they stop peeing away calories. Because of the epidemic of obesity now in type 1, it really is a game changer. So when you think about things in the last 20 or 30 years, well, you've got the glucose sensor, that's the biggest. Now you've got the automated insulin delivery systems, the pump sensor combos. So I'm talking now in terms of treatment, not in terms of cure,
Sure.
And then, but I think in terms of drugs, yeah, we've seen improvements in different insulins that do what we want as far as timing is concerned. But this class of drugs, GLP-1 and then the tirzepatide, which is GLP-GIP, these are going to be massive game changers. And really hope that we do see success with the semaglutide study and then some FDA approval for that.
It's really been amazing. I have permission to share. My son started on tirzepatide as we're taping, I think it's about 6 weeks ago. And he said to me, he was diagnosed with type 1 before he turned 2. And he said, I never remember feeling full. And, he's not eating as much, obviously. He's still ordering the same amount of food and he's eating like half of it. But he said so far, and his insulin needs have already dropped by about 20%. But so far that mentally has been remarkable for him. And I'm not sure what any of us expected, but I didn't realize he'd never felt full. And that was you mentioned, Dr. Spitz, that anvil on people's heads with type 1. I mean, what a burden. I didn't even think about that as we talked about it a little bit when he was growing up, especially when he was in puberty, how hard it is not to eat too much. But I'm so interested, excited, and optimistic, and fingers crossed he continues to do very, very well. He's on a very low dose. We're ramping it up with his endocrinologist very slowly.
So there was just something I thought about later that you might want to back in with the insurance, kind of back to the coverage of that. So I was just thinking about this when you were talking about how your son got it approved. I have found that there are like certain insurances they are more open to listening to the clinician's input. And I'm not going to, list off who they are and what they do, but we don't have one of those. Trust me. This was a fight, and I'll share at some point, but oh my gosh, but go ahead. Yeah. Well, and I don't know if your listeners are, outside North Carolina as well, but, some of our state health plans and our marketplace, they are much harder to get these medications approved. Usually we see it more so in like the private companies. And just some recommendations for patients or advice going through this is what I always say is talk to somebody at your company, say like, hey, my endocrinologist, my provider wants me on this medication. Which tier in our medication, which option do you think is going to give me the best likelihood? Because yes, they may have to pay a little bit more per month for that insurance to lower their deductible or to get that category of, yes, we will approve weight loss medications, because there are some insurances based on tiers. One will say we cover weight loss meds, others say we don't. And when they say we don't, the likelihood of getting it approved is it's very, very small. So, taking that into account and having that conversation with their HR benefit enrollment people, with the marketplace insurance here in North Carolina, I tell people to call them, talk to them, see what the lowest deductible is. I don't have a lot of success with getting obesity medications approved with the marketplace insurance, but it really, at the end of the day, comes down to the insurance coverage. And there's only so much your doctor, your pharmacist, anybody can do if your insurance is just that limiting factor. So that's really the first conversation that they have to have. So Dr. Spitz briefly mentioned this before about the direct to consumer from Eli Lilly and Wegovy. And I do think this is important because I think with these restrictions now that have been put on compounding pharmacies this past month or so, people are probably going to be going more in that direction. And they do have for tirzepatide, the 2.5 milligram vial for $349 a month. And then the next ones, 5, 7.5, and 10 are $499 a month. However, they do have restrictions, and it's important why they have those restrictions. So the restriction is they have to refill at least every 30 to 45 days. And the reason they do that is because these are single dose vials. And so what we're seeing a lot of people are doing this microdosing. We've heard that term. It's a very, it's the cool term now. But something to keep in mind, what people need to know is that the difference in a single dose vial and a multi-dose vial is a single dose vial does not have that antibacterial or microbial preservative in it, whereas the multi-dose does. Basically what that means is if you inject multiple times into a single dose vial, it's at increased risk of causing infection because it's getting microbes, bacteria in there. So these are single dose vials that they send a patient, and they probably do that for that specific reason because they want patients to be filling it every 35 to 45 days. They make more money in the long run. But on the safety side of it for the patient, they do have to take that into account because they are at increased risk for infection because of that.
I'm so glad you brought up microdosing. I did have a couple of listeners who said this is the way to go. And I wanted to ask you about that because, gosh, again, we have, as I'm sure you know, the type 1 diabetes community, especially my podcast listeners, I'll give them credit, super smart. There's a lot of DIY stuff. There's a lot of hacking going on. And I would include this in that category. I have heard that if you're going to microdose, it's better to do it with semaglutide than with tirzepatide. Can you comment
only do
on
it
that?
with semaglutide.
Ozempic.
So first of all, that's true. Only Ozempic. So first of all, the phrase microdosing, the word, this is not psilocybin, okay? This is not 9 perfect strangers. These aren't magic mushrooms. All they're saying is using a low dose.
Yeah.
Yeah. The only one where you can actually use clicks and really micromanage the dose is Ozempic. That's the only one. So this concept of microdosing.
Oh, but wait a minute. I'm going to blow your mind. What about people who get a vial and a syringe and they do it instead of once a week, they do a little bit Monday, a little bit Wednesday.
So where are those vials coming from? That's the question. If they're coming from compounding pharmacies, that's where it starts to get murky, because we just don't know where that product's coming from, right? They could be a very legitimate pharmacy, compounding pharmacy. It could be coming from the drug company or wherever, but it could also be coming from these
someone's basement.
Exactly. So, and then taking into account what I was talking about before with the single versus multi-dose vials. So yes, in terms of the actual drug that you're getting, I think we're both on the same page with that. And Dr. Spitz kind of introduced me to this because I think everyone was a little nervous to do this at first, but doing with the Ozempic pen, we'll say, hey, click up 9 times to get, 0.125 or something really, really low, because we know you're at increased risk for this and we are able to slowly get them up. But when it comes to the vials, that is something that we really can't clinically speak to because we just don't know where that product's coming from.
Well, we can speak to it. It's a bad idea. It's a bad idea. Well, this microdosing is just a fancy way of saying using a low dose when you have difficulties tolerating the higher dose. I've got patients for whom they've responded like gangbusters, and so we actually have to cut back on the dose so they don't lose too much weight. So we will, if they're on 0.5, if they're on Ozempic, I'll have them go to 0.375, count the clicks, go in between. I don't call it microdosing. I just say we're adjusting the dose.
Got it. Thank you so much, both of you, for joining me. Before I let you go, my listenership is international. It's not just in North Carolina. Where would you send people? We're talking United States information mostly on this program, on this episode. Where should people go? Call your endocrinologist. If you don't have an endocrinologist, call your general practitioner. What's your advice?
Yeah, start with your primary care doctor. We're speaking now of type 1 diabetes and obesity. I would say start with your endocrinologist. And if you're lucky, like I am, you have a great clinical pharmacist that you work with to help you out. Because there's a big shortage of endocrinologists. We're very overwhelmed. And so I give my patients the time, but Georgina, she can get to focus on really the laser focus on that. And my patients are very happy for that, as am I.
Well, I've got to leave it there. That's great. Thank you both for joining me. I hope you come back. We can continue the conversation. Yep. But thanks so much for all the information for the time.
Oh, thank you.
Pleasure.
I am also going to link up Dr. Adam Spitz's book. It's called EMR. It is a medical thriller. It's fiction. It's about sentient artificial intelligence in a hospital setting. I'm going to grab it. I think it sounds great. He didn't tell me about it. He didn't ask me to promote it. I found it when I was looking him up, as I do all of my guests. So sorry I didn't ask you about that, Dr. Spitz, but I'm looking forward to reading the book. And of course, I'm really looking forward to learning more about these GLP-1 medications and the studies for people with type 1. As I said, we'll likely learn more at ADA, and certainly this is something that is ongoing. I will definitely follow up and do more. Send me your questions. Let me know what you want to hear more about. Stacey at diabetes-connections.com. Thanks as always to my editor, John Buchanan from Audio Editing Solutions. Thank you so much for listening. I'm Stacey Sims. I'll see you back here soon. Until then, be kind to yourself.
Diabetes Connections is a production of Stacey Sims Media. All rights reserved, all wrongs avenged.